Hello, and welcome to my talk today about a case for implementing physical activity as a fifth vital sign. I will be making my case how I feel clinicians and health system as a whole should make physical activity as a fifth vital sign, and I hope to provide you with evidence why we should do that, um, and connect ideas, different ideas together to bring to why we should bring this forward, and also I will use some of my own philosophy in why we should do this. Thank you for being present and tuning in. So, to begin with my disclosures, I have no disclosures that I need to make at this point in time. A little bit about me before I start, which because how I developed my philosophy in this field. I'm a family medicine trained physician. And during my residency period, which ended about 3 years ago, I lost about 70 pounds during that time. How I did this, I learned from personal trainers about the science behind weight loss. And then while I was training, I've decided, hey, I would like to implement this for my own patients. So I did a scholarly project while I was in residency, helping my own patients. As I left, I am currently a practicing hospitalist, but I do lifestyle and obesity medicine on the side, and I became board certified in obesity medicine. So we see we see in in today the internet in our everyday life, we have positive quotes everywhere, and a lot of them dictate around exercise, about how we can empower ourselves, how we can transform our health, how we can live longer with increasing your activity, exercising, picking up the weights. But why haven't we adapted this? Why haven't clinicians adapted this? Why haven't clinicians learned how to utilize this for patients? Why hasn't the health system adopted this? So these are some of the thoughts that we often think about, and I'd like to create my own proposition to slowly adopt these ideas that we see often. And what I'd like to communicate is a vision for a better way of doing healthcare. That is one of my objectives. Explore and explain the why behind a new approach to highlight activity, and ultimately use it as a fifth vital sign. I'd like to talk about the benefits and importance of exercise, which is a subset of physical activity. I'd like to review evidence-based metrics, how we evaluate physical activity levels. I'd like to talk about how we can achieve our physical activity goals, help our patients achieve them. I'd like to talk about the equivalent of the SMART method in the physical activity terms of how to prescribe physical activity for our patients. Then I'd like to, review resources and opportunities that we have to grow as clinicians. So, a little philosophy to start with. So we as clinicians, we often feel like we are managing a host of chronic disease that are coming at us like an avalanche. I, as a practicing hospitalist, see this every day in the hospital setting with uncontrolled hypertension, diabetes, heart failure. I feel like I'm constantly diuresing, constantly titrating insulin, constantly controlling someone's blood pressure in the setting. And we do that at every level of clinical practice, to from outpatient to inpatient, and telemedicine. So, how is there an opportunity to change this? What if we could focus on fewer things every time we were in the clinic? What could we do? Is there a way to do that? Because the modern clinician appears unable to keep up with this avalanche. And it's not like we haven't thought about this before. It's an age-old saying that at this point, that an ounce of prevention is worth a pound of cure. We've been trying to close this figurative faucet of medical ailments for some time now, and instead mopping them up, doing a poor job at it too, mopping up this mess, as this doctor's doing in this image below. And idealism has not met practical methods. I believe we have to be aggressive in order to achieve our goals. I believe we need a very forward approach to health optimization. Every time our patients step into the PCP office, it should be to get them one step closer to their optimal health and body composition. We should always be highlighting and addressing the barriers for them to get there. Why are we not able to get here? Is it the mental health? Is this social? And those are often more challenging. And then we have to think 5 to 10 steps ahead to solve these barriers. Is it physical? We have to address those. And we should chase down health instead of trying to control the disease, emphasizing the prevention. How do we do this? We set goals. We set goals for our patients that are sex specific, age specific, and ability specific. We set cardiovascular fitness goals, often identified as VO2 max goals, something I would like to highlight as we move forward. We set body composition goals. We set goals for them for macronutrients. We set deep prescribing goals. That means when a patient comes in to our office and they're on multiple medications for chronic disease, we identify which of these medications can we help get them off. Can we touch them off these blood pressure medications? Can we get them off these diabetic medications? We should set these goals when they come in. So briefly, I'd like to talk about what are our goals. What are these goals? We can have specific goals, but what about nationally recommended goals that we have? We do have them. Are you aware of them? The nationally recommended goals for adults are 150 to 300 minutes of moderate intense activity. And that means 30 minutes a day, 3 to 5 days a week, with twice a week of strength training. This has been noted to add up to 3 years of additional life for the average person. And so that is a baseline we are not meeting as average Americans, maybe not globally. Now, there are different goals for weight loss. You increase those minutes up to greater than 250 minutes of moderate intense activity. You still do two days of strength training, but you bump those steps up to 5 to 10,000. For school-age children, 60 minutes of moderate to vigorous activities daily. This is important for their cognitive development, and builds long-term habits that will make them healthy adults in the future. Now, how do we achieve our goals? I'm getting a little philosophical here. There's data here, but bear with me. I believe we achieve our goals now by tracking physical activity as a fifth vital sign. Getting a little more philosophical, we are all aware of the law of attraction. Your mind is like a magnet. If we put positive intentions out into the positive goals out in the universe with positive intentions, with positive inputs, with action, we should hope that we'll have returns, positive returns. And we can measure this in many ways, and it has been shown to yield results. And this is the same way I want to think about tracking. When we track more metrics of health, we get more health. When we track more steps, we get more fat loss. When we track workouts, we build muscle. We put more weight on the bar that our patients can lift. We put more muscle on, we increase our health span, our lifespan. We start tracking fibrous foods. We decrease our cholesterol. These are all measurable things that when we start tracking, we will get more of it. Now, I'd like to talk about what I like to track as a physical activity as our fifth vital sign, but I like to paint you a picture of where it lies. We already do use vitals. Why do we use them? Because they give us quick access to a quick profile to someone's health. They can help us detect medical problems real quick. Are their heart rate high? Do they have an atrial, form of tachycardia? Are they in sepsis? Are they breathing heavy? Do they have COPD? Are they volume overload? We can quickly tell things about them. And they're often context specific. The main four ones are heart rate, blood pressure, respiratory rate, and temperature. But did you know that oxygenation was the fifth one? And it's not always used in every setting. And the other vitals we use, like end-tidal CO2, it's a vital we use when patients are on opioids. Gait speed, shortness of breath, functional statuses. Now, different types of physical activity is already used in certain settings. In the rehab, activity is used as a function of the patient's health. So we already actually using it, but we haven't used it as something readily at every level. And that's my hope that we will do in the future. So getting a little bit more philosophical, I want to talk about something we've tracked before, is pain as a fifth vital sign. There's more here than I am knowledgeable about, and I am knowledgeable about and need to learn more, but I think there's big picture ideas we can take away from utilizing pain as a fifth vital sign we've used before. Pain is often an end state disease and often subjective. It's often because you have trauma, cancer, inflammation, arthritis, or other end stage diseases. It often becomes very subjective. And without someone who's trained appropriately, it became something very hard to control and treat. And the more we asked for it, the more we got, the more we started prescribing for it. And the more we chased this metric down, we started down a path of what we could say is healthcare instead of sick care instead of healthcare. I firmly believe that we should be treating pain, but there's the how we did it has room to be improved upon, and we should be careful of how we track it as a fifth vital sign, because that might be the wrong approach and how we choose to do it. And even if it is, I think we should be careful of where we put it. Is it the fifth one? Or is it the eighth or ninth or 10th? So I think we have to be careful what we track, because we might actually get more of it, philosophically. So why not track physical activity? If it's a vital sign that indicates a status of health, why can't activity be used as a vital sign and a barometer with low activity telling you, hey, this is an indication of poor health, and appropriate activity indicating good? It does tell us that, and it should be used more that way. But what is physical activity? Let's start there. We oftentimes don't know enough about it to counsel. Physical activity is actually any type of movement. If I get up and go get myself a cup of coffee, that's physical activity. That is different from exercise. Well, that is different from exercise in the fact that exercise is a subset of physical activity. When I get up and lift weights, that is physical activity. But when I lift weights designed to improve my fitness, when I do 10 reps, 2 sets of them, that is exercise. And that is something we have to communicate to our patients when they say, but doc, I work in construction and walk all day long, or I work at the grocery store and walk all day long. I'm getting my exercise. They may not be necessarily getting their exercise. They may be getting physical activity in the form of movement. And what we have to highlight is when we track physical activity, we should be talking when we optimize, when we counsel, we should be able to differentiate the type of physical. Now, why track? Tracking is data. Tracking allows our patients to see what they're doing. Tracking allows us to see what our patients are doing. It allows us to have a conversation about their activity levels. Now, a simple thing that I do is when my patients come in, I ask them to see their iPhones if they have one, and you open up their health app and open up to how much steps. Oftentimes, it is less than 3,000 steps per day. And they're surprised, doc, I didn't know I was only getting this much. Now we can begin. Now we can highlight where they're at and then set goals. And this allows us an opportunity to help change our patients' behavior, rewire their brain, do cognitive behavioral therapy, and allows our own patients to tap into the power of journalism for self-transformation as they continue to track and record what they're doing. Now, why should we track this? So many reasons. One, we need more of it. It's been noted to be a global pandemic now. And the AMA declares obesity as a disease. And sedentary activity levels is a huge contributing factor to it. Just 1 in 5 US adults exercise daily. And greater than 75% of kids are less active than recommended 60 minutes a day. And when we think about cardiorespiratory fitness as a number one cause of all cause mortality, and we have such low activity levels, we are not doing the single most thing that we can do. Because nationally, the prevalence of activity is high. Inactivity is about a quarter of our population is inactive. And when activity contributes to 1 in 10 premature diseases and causing us about $117 billion in annual healthcare costs, that is something that we realize, hey, we need more of this. And we begin by tracking it and making ourselves and our patients aware at each opportunity we have to discuss. So I want to ask you a philosophical question. Would you rather increase someone's dosage of insulin or increase their number of steps that they're doing? I'd like for you to think about that, because that is a realistic pathway, 2 realistic pathways you can take, because you can increase patients' physical activity and improve their insulin resistance and decrease their need for insulin. You can help treat coronary artery disease with it. And in certain settings, blood pressure can be managed with increasing activity. And that has been, and I'm not saying if someone has a systolic blood pressure of 180,000, hey, we need to work on increasing your steps and focus on that as the primary thing. No, put them on some lisinopril, start walking. But those patients sometimes with systolic blood pressures of nearly 130 and creeping up there, start them on a walking regimen. That has been proven to be effective. Physical activity has been shown to improve status in cancer, inflammation, obesity, which has, a common root of inflammation, dementia, and an ability to deprescribe. And physicians just need to utilize it more. We just don't utilize it enough. Now, treating and preventing. This is a graph that shows how getting that moderate intense activity we talked about, 150, 300 minutes. That is how we can see how we can decrease the hazard ratio from 1 to almost half just by getting that 150 minutes of moderate intense physical activity. At that point, you reach that about eight metabolic equivalents. You reach 70% of benefit. You reach about 70% of the benefit of physical activity by meeting that 150 to 300 minutes. That is impressive. So, half of all American adults have one or more preventable chronic diseases. And 7 of the 10 of them are influenced by regular physical activity. But 80% of people are not meeting the guidelines. And then when we have this huge astronomical cost, like $117 billion, I think there's room here. I think there's room for improvement, and we have to try to get them. Now, physical activity, we can optimize health, not just prevent, but optimize. But how you respond to it depends on your genetics, the type, duration, and intensity of how you do it. It shows you quick benefits right away. You can have benefits right away in each session. Then you have benefits that are more longitudinal throughout the course of your life. They improve your mental status, sleep, overall quality of health, your life, your health span. Then your metabolism, immune health, density, bone density, and preventing risks and falls at home as you increase muscle mass. So across the board, like, it's not just prevention, it's optimization. And we have to learn how to utilize that. One of the things that of physical activity that I want to highlight is VO2 max. It is the volume of oxygen consumed by your body per minute in milliliters per kilogram per minute. The maximum amount your oxygen can carry to tissues. So this is the strongest predictor of cardiovascular disease and death. Strongest predictor. And it's modifiable, and we have control. Okay. So a low VO2 is a negative predictor of mortality. That's independent of obesity, high blood sugar, and everything. And high VO2 is a predictor of health, independent of those chronic diseases as well. And increasing it by your metabolic equivalent, okay? These are metrics of VO2, kind of metrics of VO2 max, about 3.5 milliliters kilogram a minute. Increase it by 1, increase your survival by 10 to 25%. And this has been many studies showing that. So it's essentially a marker for the work you put in over the course of your life. You don't get a high VO2 max overnight. You build up for it. That's the work you do, the jogging you do every week, and like the running, the sports you play, it builds up to your VO2 max. So this shows hazard ratios. So I want you to focus on two things here, okay? The low versus elite. When we take VO2 max of low performers and elite performers, the hazard ratio was 5. Now the hazard ratio of whether you have diabetes or not is 1.4. Okay. Now, can you imagine a situation where you focus on bringing, if you want to optimize a patient, bringing their VO2 max up to as high as you can when you have a hazard ratio of 5, or controlling their diabetes? You got to focus on one thing: how big the hazard ratio is. Now let's dial it down to above average. VO2 max low to above average. The hazard ratio is 2.75. And then diabetes is 1.4. If you had to focus on controlling someone's diabetes when they come in for longitudinal health versus increasing their VO2 max, what would you focus on? It's something to think about. And that's independent of these chronic diseases. This is another graph, shows you, hey, as you improve your VO2 max, your adjusted hazard ratio comes down. The higher it is, the lower your hazard becomes. You see a similar trend here? This is the graph on the left with the VO2 max as you improve it, and this is your hazard ratio of mortality with moderate, intense, and vigorous activities. And I think what we should propose to shoot for is that moderate, intense group for most of our patients, because we're not achieving it. We're not there yet. So it's a similar trend. So we can connect. This is for us to understand what all this means, how all this data connects. So, but we should track this to be beyond the clinic, because we can monitor and influence health outside of our clinic. Because when we as physicians in the pandemic lost a lot of control of our patients. We weren't able to see them in the pandemic. We weren't able to go to them, and we had to rely on telehealth. And we weren't, and one of the biggest things that's changed during that time is their activity levels. They were moving less, and we had no idea. Now we have remote patient monitoring, but this evaluates blood pressure primarily, but that's almost an end state value, end state vital sign, and we chase that down with blood pressure medication, which is fine. We should treat that, but we weren't able to see how active people are. And I think there's an opportunity for us to track activity levels more and create a collaborative model that extends beyond our clinic to truly create an integrated model. And this may involve working with gyms, fitness trainers, and much of this can be done remotely. So in the set point in obesity medicine, which I'm board certified in the College of, we have a set point theory that there's different things that bring together, creates a set point for where patients weight lies. That's environmental, behavioral, genetics, etc. And I think we should empower ourselves to learn and talk to our patients about where their energy levels are, energy intake and expenditure, and empower these patients to, hey, we can change the set point by increasing our activity levels. That begins with understanding where we are, assessing the data, and slowly change the bar and empowering our patients to do so. Now, anti-obesity medications. Now, these are huge. We all know about them right now. Ozempic. Ozempic is making waves. And this is even more reason why we as clinicians should be more mindful of physical activity. Partly, mostly because of how to address the conversations around this. Because these medications have been generally great. You see a good amount of weight loss, around 15%. It's a safe estimate of weight loss on some of these medications long term. But the criticism is, hey, are patients losing a lot of muscle mass on these? And we see news of this as much as recent over the last few weeks, or of patients losing muscle mass, and it's likely going to continue on for the next few years, this concern. But the thing is, objectively, patients will always lose muscle with any type of weight loss, even without medications. The big thing we want to focus on is what percentage they lose. Always, when you lose weight, you're going to lose more fat than muscle. It's always going to happen. But how do we retain as much muscle? And there's criticism that, hey, are patients losing as much as 39% of their muscle mass? Now, let's say they do. Even if they do, their overall body composition will improve because they lose more fat. Now, that's not the case, though. Patients, on average, probably lose around 20%, maybe 39% is a very high value that I wouldn't quote that, but it's the upper end. So our goal is then to make sure these patients do not gain the weight back. And this often happens with getting off the medication. And then when you have these cycles, unfortunately, when you gain this weight back without and not gaining muscle back, you run the risk of sarcopenic obesity. So for us to kind of prevent this and optimize these medications, we have to talk to our patients about resistance training, increasing activity levels, and if they decide to go off these medications, uh, finding their physical activity levels that highlights a set point um, that we decide on a shared basis and try to keep them there. So it's an important part of a holistic process of addressing this. So let's get a little bit more philosophical. How would you like to create your own patient? We're able to create our own players when we play video games these days. Let's say if you're playing a basketball game, you can pick how tall they are, how fast they run, how high they jump, what's their percentage, free throws made, their shooting skills, etc. But what if you could do that with your own patients? That's how I would like to think about with your vital signs. See, because we are the main four vital signs: heart rate, blood pressure, respiratory, temperature. We have limited control over them. Really, we can adjust heart rate with medication. If they're tachycardic, high heart rate, we can put on a beta blocker. We can bring that heart rate down. We can do that for the blood pressure as well. We can give someone a breathing treatment and increasing their respiratory. We can give them Tylenol and change their temperature. But physical activity, that is something we actually can change today, tomorrow. We can dial up this knob a lot more acutely without any foreign intervention and without a prior authorization either for any meds for these vitals. I want us to think about physical activity as this knob that for our patients that we can change with how well we're able to connect with them, educate them, empower them, and coach them. And long term, I want us to use that knob to bring down their heart rate to an optimal level, bring down their blood pressure to an optimal level, the respiratory rate, and even their temperature by reducing their risk of infection. Sedentary behaviors lead to diabetes, diabetic ulcers, infections, osteomyelitis, increased mortality. That begins often with physical activity. A little bit about my work. I talked to you guys about I did the scholarly project. And I took patients that followed up with me at least for 4 months, 4 visits, and I tracked the daily weight, steps, and servings of vegetables. And I found out many were getting less than 2,000 steps a day, and averaging less one serving of vegetable per day at best. And I created a simple, kept it very simple, creating a tracking tool. And I primarily tracked their steps, the morning weight, and servings of vegetables. And I had them track it and bring it to me to discuss during their visit. This is while I was during residency. And then, we discussed it at every visit. And one of my most successful patients lost 74 pounds, decreased their A1C from 9.9 to 7.2. Their microalbuminuria resolved. I took them off their blood pressure medications, increased their self-esteem, improved their joint pain, and helped them change dietary habits over time. Another patient on multiple blood pressure medications helped them increase the best servings vegetable from 2 servings to 4 servings over time, increase their steps. He was getting less, 2 to 3,000 to 10,000. I only helped him lose 4 pounds, but he was able to get off of 3 blood pressure medications. And that goes to show how physical activity, even if you don't lose weight, you can have metabolic effects that are beneficial. Um, so another case that I have is I have a patient, a 53-year-old male, who was limited. His physical activity was limited because he had Charcot's foot from diabetes. So he was only getting about 1,000 steps. So we got him to 3,000 that we agreed upon with this podiatrist, and we were able to because we were limited activity, we increased his vegetable intake, 4 to 5 servings a day of whole food, and he reduced eating out. And he was on 40 milligrams of lisinopril. We titrated that down, got him off, and his hydrochlorothiazide as well. Titrated him off all his blood pressure medications, and lost 10 pounds. So my conclusion that, you know, diet and exercise works almost for everyone, and tracking and improving diet with more vegetables, increasing overall physical activities levels are overall, you know, foundational parts of obesity medicine, constant for everybody. And, we need to be able to do that. Um, so the challenges that I saw were the physical limitations of increased, physical activity on the physical activity side. Like Charcot's foot, diabetes, you get these structural issues with your feet, you get the neuropathy or the arthritis, other structural difficulties. And people who have, these physical activity ailments, like less than half the adults are active, they have one. So we need to be able to talk to their professionals like podiatrists or physical therapists to assist them and getting them where they need to be. Mental health and anxiety, fear of discussing, their physical activity levels. I think, um, I think like I have patients who do not want to be on screen because they're too anxious. So how are we going to reach them? That's might be through telehealth. That might be through a phone call. We have to meet them where they're at. Then closer monitoring. Hypotension and hypoglycemia are a thing when people increase their activities. They're on medications. Uh, I have a patient who I was decreasing their blood pressure medications, and then they came in, I reduced their dose. They unfortunately passed out on the way out because their blood pressure was low, and that's something to consider. We have to be careful. But it's a double-edged sword because it gives us an opportunity to prescribe. So exercise as medicine. We talk about all this, and for clinicians, is something that I think we have more to learn and grow. But it is an initiative that's taking hold, and we should be aware of these initiatives and work with them. There's an exercise as medicine initiative to make a physical activity assessment and promote it to clinicians and make it part of the healthcare team. And they've developed like a validated screening tool, talking about how often, how many minutes people engage in physical activity, and how many days per week they do it. And they use it, and they educate about physical activity levels as well, and they create a guideline to treat clinicians and patients alike to do it. They talk about moderate intense activity, and a quick way that I want to make sure we talk about is moderate intense activity is activity that you can do. um, you can you can still talk while you're doing it, but you can't sing because you're a little too short of breath to sing. And that's brisk walking, slow biking, tennis, various forms of dance. So that's what that provides. And vigorous activity is you can no longer talk during the activity. It's, for most people, it's jogging, and so some people can talk during that in high levels. They talk about, limitations, how to guide. They try to keep things very simple in their education. They have a comprehensive approach, talking about the stage of this change, how to prepare patients and clinicians alike, how to create a script. And it starts by just this validated, screening tool that the support staff is able to do. And it kind of guides you through physicians interpreting this, screening, this screening questionnaire, and then creating the script based off of it, and also connecting with local uh, trainers, coaches, and also how to integrate them in your staff and utilize them. So I think they do a very good job. We should be aware of them. Um, they have the 5 A's and how to assess. You assess, advise, ask, advise, assess, assist, arrange. They walk you through do that, how to create this plan. And then they teach you how to prescribe it. Uh, they teach you about how to choose the frequency, intensity, time, type to to create an exercise plan. It's, part of the SMART method when it comes to when if you're familiar with the SMART goal setting: specific, measurable, achievable, relevant, and time bound. And the FIT is, I would consider that's the equivalent for physical activity. Um, so I want to go into I'm gonna go use an example of fit soon. But how do we make this work? You know, we just need to adopt it. We need to collect it at every visit. All specialists should be involved. Got to make it quick and easy. But including the EMR, I think Kaiser started it. And we need to be able to bill for evaluating, screening for physical activity, counseling, and we just need more incentives to do that for clinicians to utilize this. And ultimately, we need a collaborative model to do it. My specific proposition is to track steps. It's a very simple marker for activity. You can do it every day, use it to fit into everyday activities. You bypass barriers, you don't need a prior authorization to create a script or a walking class. There's been data to show lower mortality with each steps, and you can do it at every visit, you know, easily celebrate success, and the benefits is like it achieves all the benefits of regular physical activity. Um, so like it's already highlighted, walking is easiest physical activity to build these national recommendations. We don't want to discount walking. Walking briskly about 2.5 miles per hour faster is considered moderate intensity activity. That 150 minutes, we can accomplish this by walking more. And there's the data relation of daily step counts to all cause mortality and cardiovascular events. There's data to show that hey, there's a dose response relationship. This is a meta-analysis of 111,000 people. At 2,600 steps, we start to see cardiovascular benefits. And, we see them up to 7,200 as you go. And there's more all-cause mortality when you go up to 8,000 or 8,800. So what would this look like? So what it could look like is this. Um, if you had a snapshot of about no matter what setting a patient was in, this quick snapshot of 1,563 steps. Let's say if they were in the ICU setting, then they would see, hey, this is what a patient with 1,500 steps looks like in the ICU setting. That could be compared to patients in the general medical floors, and we could counsel patients at every level and be able to increase that step, and that could probably correlate with where they end up. And similar to COVID vaccinations, you vaccinate for COVID, then you likely end up on a general medical floor when you have back in the day COVID pandemic. If you weren't vaccinated, you end up in the ICU, and I would bet there's clear correlations with how many steps you're getting, and then where you end up when you have a health ailment. And then when you're in the outpatient setting or inpatient setting, this is something every clinician can talk to patients about. This is modifiable. You can use it to achieve that moderate intense activity levels, and you can get 70% of health benefits through there. So that fit prescribing physical activity. I want to use a real world example how to get majority of patients to 70% of health benefits for your frequency. So 5 days a week, 5 days a week. That's how frequent. Intensity, 3 to 4 miles per hour, where you're slightly short of breath. There's different people define, the sources how fast you should walk when you're short of breath. Time, 30 minutes. 30 minutes. We know exactly how much. The type, it should be brisk. Be brisk and you're short of breath. So you do when you crunch the math, it comes down to about 4,000 steps every 30 minutes. Okay. Now you have this is the prescription to get our population healthy. Now the average person's pace is about like 1.5 to 3 miles per hour. It's about 2,000 steps per mile. These are some metrics to utilize. Um, and the briskness sometimes can be a barrier. Not everyone can walk that fast. So um, I don't, the cadence, matters. Cadence does help, but if they can't walk that fast, any walking is good. And when you get to these high level step counts, 8,000, 10,000, 12,000, it might not matter as much that they're walking first, you know. So there's nuance in how we communicate it because sometimes patients get caught up on the simplest things, oh, I can't walk that fast, so I'm not gonna do it. So then you just say, hey, just walk, do whatever you can. And my plan is general. I just have them track for the first month and then increase it by 2,000 steps and shoot for a goal of 8,000. So as you can see, walking on every, categories when we talk about intensity activities, moderate intensity activity is there. And it helps, cellular immunity, insulin resistance, and increasing the VO2 max is dose dependent. The more you do it, moderate, intense, you pick it up, you get the vigorous, activity levels, you get the higher VO2 maxes, but we hit a lot of our benefits with the moderate intensity activity. And we talk about a lot of the metabolic, effects of exercise, and that is met during these moderate intense periods. We specifically talk about cellular immunity, insulin resistance, and that, a lot of it's, at the cellular levels. When we get this, we hit this moderate intensity, we increase oxygenation, we have these positive effects of IL-6 that changes a positive cascade and that leads to anti-inflammatory, cytokines that ultimately, you know, um, improves our cellular health, increases insulin sensitivity, reduces diabetes, reduces insulin resistance, etc. You need these at this moderate intense activity levels. So in today's age of technology, you have these apps so much, we may only need is a pedometer, a simple pedometer, a few dollars, and a sheet of paper, to record this. That is our simple thing that our patients need to get started. So let's reduce the barrier of entry. And to do that, we just need to educate ourselves and educate ourselves. But I think we like it's already happened. There's already initiatives to do that. I just want to highlight this, call to action by the Surgeon General to step it up. Now it's a call recognizing how just walking in itself how incredibly beneficial it is to prevent disease, optimize health, and its initiative to create a community for walking, create these walkable communities, and educate professionals about how to utilize it. And again, like we discussed, collect data, because the more data we collect, the more empowered we're going to be, and the more we're going to realize that, hey, this addresses a lot of our, needs as individual patient care and population health. So what else can we track? We talk about physical activity and particularly steps. There's other things that we do track, and we can track, you know, um, standing. Even 2 hours a day decreases all-cause mortality by 10%. Increase that to 8, 24%. We can track flexibility, body composition, which is incredibly important with muscle mass, waist circumference, we can predict metabolic health, just strength in general, metabolic equivalence is, the VO2 max, some metrics of that, and Borg scale perceived exertion, percentage of maximum heart rate. Those are all different things that we can track for our patients. So I do want to talk about, why we do as physicians struggle. It can be, summarized in a nutshell of how we approach it: eat less, move more. The problem often is we want our patients to be like, hey, you should exercise, you should do this. And we expect them to go from A to Z when they may not know how to get from A to B. And it leaves them confused and spinning their wheels if we're not able to counsel appropriately and guide them, along the journey. So we have to take more ownership and guidance. We have to be there, and see the data, the raw data. We have to learn the language of fitness and speak to our patients in simple ways so they can understand. And we need to know when to refer and be aware of resources to do so. So what is a language of fitness? It's being able to talk about steps, macronutrients that we haven't talked about the food part a lot, but it's knowledgeable about that as well. Basal metabolic rate, NEAT, thermic effect of food, VO2 max again, the metabolic equivalents of VO2 max, talk about that, body composition, weight loss versus fat loss, which is something that we do not think about enough, and know about resources. There's so many resources, that are available to us in our communities. And if we're not able to counsel, we should be able to know when to refer to for more counseling. And the American College of Sports Medicine has great resources like the Exercises Medicine program. So the future of medicine, it will be, whoever creates a successful model that implements it, will have a breakthrough model in exercise medicine, and it will be surrounding, tracking body composition, highlighting optimal skeletal muscle mass, VO2 max, increasing that, and then using food as medicine. I think there's a lot of room for that. And collaborations, gyms, other lifestyle-based establishments. This will be the future of medicine. And it's coming. American College of Sports Medicine have integrated, work with a lot of health groups to bring physical activity as the fifth vital sign. So it's, there's many aspects of it, and we, us as physicians, should support this, get on board, and help move this initiative along. So in summary, we have to implement. We take the steps. It's in our hands. We the knowledge is there. We know how physical activities can help our patients get to their optimal health. And I want to highlight how steps, simple and effective method to begin, and then we double down on the physical activity to optimize their health. And educate ourselves. Continue educating ourselves in this field for our patients, for our population health at large. I want to leave with this. I wish it was we had just had a pill that we could get all the benefits of exercise. And we got to learn. Like the more we knowledgeable become, the easier it gets. The connection we have with our patients, the easier to communicate the relationship we have, and then when we know our topic, it becomes more digestible when we have these conversations, connect with them, and get them from A to B. And hopefully we can make it easy, as chewable as just have a normal conversation. Here are my sources. Please reach out if you have any specific questions. Here's my email address. You can reach me here. We can talk more. Okay. Thank you for tuning in to my presentation. I appreciate your time.